joined, please drop your title and affiliation in the chat so we can get a sense of the audience and see who's joining with us today. Next slide, please. So there will be continuing education credit. If you are interested in that at the conclusion of this webinar, we hope those in attendance will have gained insight into the learning objectives listed here on this next slide. At the end of the meeting, we'll share a link in the chat for the evaluation survey that's required for those interested in earning continuing medical education credit. And before we get started, let me introduce myself. I see a few people in the participant list that I recognize, but you're not all friends yet. I'm Lucy Savitz. I'm a professor in the Department of Health Policy and Management at the University of Pittsburgh School of Public Health, and I'm a Senior Innovation Advisor for the UPMC Health Plan's Center for High Value Healthcare Collaborative, as well as I'm the current board chair for Academy Health. And joining me today in facilitating this meeting is Dr. Elizabeth Cope, who's Vice President of Health Systems Improvement at Academy Health. And just so you know how this has really sort of been created, we've partnered with AHRQ and the SRC to bring awareness to and help disseminate research findings of the ongoing evidence reports published by their EPC program. So today the reports we're highlighting focus on new research in clinical preventive services, which is the theme of our meeting today. And we will have opportunities for open discussion and Q&A later on, but please feel free to use the hand raising and chat functions. I'm sure you're all familiar with those throughout the meeting, and we'll keep tabs on the questions as they arrive. On the next slide, I believe, is the brief disclosure and reporting conflicts of interest. It's actually not. It's on this slide, of which there were none to report. So if you can go ahead to the agenda, I'll just give you a brief highlight. So we're going to start with introduction of the authors, then we'll have the presentation of the first report by Dr. Cindy Feltner. There'll be some initial reactions by our discussant, Dr. April Joy Damian, and then the second report will be presented by Dr. Amy Cantor, followed by initial reactions from Dr. April Joy Damian, and then a general moderated discussion Q&A that I'll lead, followed by a thematic focus on policy equity and health systems issues that Dr. Elizabeth Cope and Dr. April Joy Damian will lead. And then we'll have closing remarks. And again, just as a reminder, if you want continuing medical education credit, please be sure to stay on to the end and follow that link so that you get those credits. But at this point, I'd like to introduce our distinguished speakers. So first is Cindy Feltner, who Dr. Feltner is an associate director of the RTI UNC Evidence-based Practice Center. She's the concentration lead in population health for clinicians in the Department of Public Health Leadership and Practice at the School of Public Health. She's also an assistant professor in the Department of Internal Medicine, Division of General Internal Medicine and Clinical Epidemiology at UNC Chapel Hill. Her report today is on the screening for intimate partner violence and caregiver abuse of older vulnerable populations. And then with her today reporting the second report is Dr. Amy Cantor, who's a professor of family medicine and a professor of medical informatics and clinical epidemiology, as well as a professor of obstetrics and gynecology in the School of Medicine at the Oregon Health Sciences University. And she's going to be talking about respectful maternity care. So we're really looking forward to hearing about this new evidence that's emerging. And then on the next slide, you'll see a photo of Dr. April Joy Damian. She's vice president and director of the Weitzman Institute. She's a psychiatric epidemiologist, a health services researcher, and a public health professional. And for those of you who are not familiar with the Weitzman Institute, it's a national research, education, and policy center that's dedicated to the innovation and impact in primary care for the underserved. So I think we've got a really great agenda for you today. And with that, I'm going to turn it over to Dr. Feltner and ask her to begin reporting on her sharing the new evidence that she's worked to generate with her team. Cindy?
Thank you so much. I'm so happy to be here to talk about our draft evidence review. I will admit to having a small technical difficulty with seeing the slides. So Taylor, I will look at my slides and just let you know when to advance.
Perfect.
Great. So first, I will admit, part of this slide set comes from our EPC's presentation to the U.S. Preventive Services Task Force. And so on the second slide, you can see the names of our full research team who worked on the report. I'd also like to acknowledge our medical officer and the U.S. Preventive Services Task Force leads, as well as peer reviewers who contributed to the draft report, which I should also say is currently posted for public comment, along with the draft recommendation statement from the U.S. Preventive Services Task Force. The other thing I should just acknowledge is that what I'll sort of talk about today in terms of just, time really will focus mostly on the intimate partner violence topic. Next slide. So I think it's probably obvious from the title. So the purpose of this evidence review was to update the review that focuses on the benefits and harms of screening for IPV and caregiver abuse of older and vulnerable adults to inform the current updated recommendation. And just for context, I've copied the current or 2018 recommendation statement below. And as you can see, there's a B recommendation for screening women of reproductive age for IPV victimization. And there's an I statement for the older and vulnerable adult population. Next slide. I think it can be a little perhaps confusing to understand why these populations are grouped in the same report. So just as a little snapshot, this slide shows the sort of history of this topic, starting from the first time that it was that it was conducted back in 1996. And as you can see, at that time, the topic was really sort of lumped and framed as family and intimate partner violence. And so over time, with each update, there have been some changes. So in 2010, the child abuse and maltreatment was split into a separate topic, and the vulnerable adult population was added. At that time, the screening only focused on women. And so in 2018, our EPC conducted the review on this topic. And at that time, we expanded to include adolescents. We also expanded to include men due to increased sort of awareness of the prevalence of IPV among men. There's some other changes as well, including more of a focus on age-inclusive language. And so for this update, just to set some context, we had an increased focus on health equity. The U.S. Preventive Services Task Force has a new framework that focuses on incorporating health equity throughout the entire process of updating and making a recommendation. And so two things I want to maybe just highlight for this topic is that, with COVID, as you all know, there's an increased shift towards virtual visits. And so that was something we looked for evidence on, and I'll come back to that at the end. So thinking about what does that mean for potential harms of screening for IPV. Next slide. Just to make sure we're on the same page, I've included a slide here that shows the CDC definition for intimate partner violence. And so I won't read this in detail, but I also want to acknowledge, because it will come up in the results, that intimate partner violence outcomes, could be reported as any type of intimate partner violence or reported as specific types of violence that focus on, for example, physical violence or sexual violence. Next slide. This slide shows some prevalence of IPV victimization in the US. Two things I think are important to call out. One is that the prevalence of any type of violence and some other categories of violence are roughly similar among men and women, but women do experience a disproportionate prevalence of sexual violence as well as severe physical violence, and also have a higher burden of long-term adverse health outcomes associated with IPV, for example, PTSD. Next slide. So one thing I want to acknowledge too is that the risk factors and issues that contribute to intimate partner violence are complex. And so this slide shows risk factors at various levels using this social ecological framework. And I think these are important to kind of think about briefly because, as I'll show you later on, some of the interventions that are effective for intimate partner violence address some unmet social needs. Next slide. And so in terms of why this topic is addressed from a screening framework, first, we often think about screening as a way to identify health problems before they become symptomatic. For example, colonoscopy to identify a polyp. And this topic is different. So by definition, intimate partner violence is not asymptomatic, but it often goes undetected or may be hard for victims to ask help or seek help, or they may not know that there is help available from the healthcare system or primary care. And so the goal is to identify abuse not otherwise known and provide an intervention to maybe reduce future violence and associated morbidity and mortality. There are also brief screening questionnaires that can be used in primary care, and I've listed a few here. Next slide. This slide, just for reference, shows our analytic framework for IPV. I won't go through this in detail because I will refer back to it as I show you some of the results for the draft report. Next slide. Also here for reference are key questions that match the analytic framework. Next slide. Here I've included just an abbreviated eligibility criteria specific to IPV. And a couple of things I want to point out is that, the studies that were eligible included, for example, screening or treatment studies that enrolled people who were screen detected. There's a body of evidence that also evaluates interventions for people who are seeking care for IPV, and those studies were not included in this report. The other thing I want to point out that is different than compared to other topics that the task force addresses is that we did include studies that were set in emergency departments. And part of the rationale behind that is that there's evidence to suggest that people who are experiencing IPV often need to seek care in emergency departments for problems that generally could be addressed in primary care. It's just that they maybe are limited in their ability to plan or are experiencing coercive behavior around limitations in terms of when they have access to transportation or other resources. Next slide. Moving on to the results, I want to just briefly summarize the results that relate to evidence that assesses the direct effect of screening, meaning studies that compare screening and a brief intervention to usual care or no screening. And so the high-level summary is shown here at the bottom. There are 3 RCTs that compare IPV screening with no screening. They all enroll unselected adult women who are presenting for routine care, and none found a statistically significant reduction in IPV or improvement in other eligible outcomes. 2 of these also reported on harms of screening, but and found no evidence of harm. Next slide. What's important maybe to sort of understand is that these are very brief interventions. And so for example, in the first row is a study set in the US, and basically women who screened positive received information that comes from a brief video around providing support and information about an IPV advocacy program and are encouraged to seek help. Other two studies below sort of provide other sort of similarly brief interventions. And this will be important when I sort of talk a little bit about the indirect evidence and point out the differences between what was provided in these studies versus what was provided in sort of a separate body of evidence focused on screen detected populations. Next slide. So briefly, as sort of moving on to the indirect pathway, in terms of the accuracy of screening questionnaires, so we identified 17 studies that assessed the accuracy of 14 different screening tools designed to detect IPV. And a couple things to know about this evidence is that these really look at different timeframes. Some studies look at the accuracy of a questionnaire to detect any lifetime abuse. Others look at the accuracy for detecting past year intimate partner violence. Next slide. A couple things that are maybe important to sort of call out for context is that all of the evidence that we identified is really limited to adults. And the majority of studies look at populations that are characterized as women. One study is limited to men only, and generally these studies don't really describe differences in sexual orientation or gender identity. Two of the new studies that addressed a gap in the research that was identified in 2018 focused specifically on pregnant populations, and I'll show you those results on the next slide. The other thing before we move forward is that, in general, the IPV prevalence for this body of literature is roughly similar to estimates that come from cohort studies about the prevalence in the general population. Next slide. So this slide is showing a forest plot that's not a pooled summary. And the way it's organized is that in the red square is the results for past year IPV, and at the bottom are results for studies that are looking at questionnaires that are specific to current IPV. And as you can see at the bottom, there are fewer of those and a lot more inconsistency in terms of the results. At the top, the order of the studies is sort of grouped by studies that were set in primary care. It's the first two rows. And below that, there are two studies that I mentioned that were conducted in prenatal care settings. And what you can see is that those two studies had fairly low sensitivity, so 26 to 50% sensitivity. And overall, studies that are sort of set either in non-prenatal care, primary care, VA settings are sort of more generally in the range of the sensitivity of around 70 to 80%. Next slide. And so moving on to interventions that were evaluated in screen detected populations, meaning these are populations that were screen detected and randomized either to an intervention or usual care. We found 13 studies that evaluated interventions, and these are very heterogeneous interventions is the sort of first thing to be aware of. And generally, as I'll show you on the next two slides, sort of focus either on populations that are pregnant or postpartum versus sort of general populations. And the majority of these studies describe the population as women as victims of IPV. 5 of these studies also report on harms, and none found significant harm associated with the intervention. Next slide. There's a lot of detail about these interventions, but a couple things I want to highlight that may help with just sort of understanding the overall picture. In the red box at the top, these are the 3 studies that evaluated interventions that showed benefit. As you can see in the second column, what was provided is much more intensive compared to the body of evidence for the 3 screening trials. So these included components such as multiple home visits. Many of these also included components, for example, that linked victims to community services that provided support with housing. They also, some provided parenting support. In the third row, the study focused on sort of screening for both IPV, but also screening for depression, smoking, and other factors that were risk factors for adverse perinatal outcomes. As you can see in the row that focuses on the number of sessions, these were fairly intensive, providing interventions over 6 to 13 sessions and sometimes following women for 1 to 2 years. At the bottom, these interventions provided less intensive services, generally counseling specific to IPV only over a brief visit and perhaps a follow-up. Next slide. This forest plot is just summarizing the results of those studies I just showed for IPV outcomes, and the order is similar to what you saw on the previous slide. And so it's really those studies that included the perinatal home visits and also counseling for multiple risk factors that showed some benefit. As you can see on the bottom, there's definitely some variation in how outcomes are reported, but the studies that focused on counseling alone generally did not find benefit or found mixed results for different types of IPV. Next slide. So this slide shows the characteristics of studies in non-pregnant populations. And what I want to just call out briefly is the difference in terms of the interventions and number of sessions or intensity. These are generally providing brief one-time counseling support or information following the positive screen without additional components that address unmet social needs or other factors. Next slide. And here are the sort of outcomes. Actually, I think I made a mistake with the order. This particular forest plot is showing the IPV interventions for the pregnant populations just for other outcomes. And so here you can see there was some benefit for birth outcomes and some mixed evidence for the mental health outcomes. Next slide. Here's the slide that focuses on interventions for non-pregnant populations. And as you can see, really the evidence was fairly limited in terms of the number of interventions that found any benefit. There are some studies that showed mixed results for different categories of violence, but in general, these did not find significant benefit for reducing IPV or improving other health outcomes. Next slide. So a couple limitations, just to wrap up. Again, this review did not evaluate evidence on programs to prevent IPV or screening, treating perpetrators of abuse. There is a body of literature evaluating those interventions. We also didn't look at whether certain symptoms should trigger an additional assessment of abuse or case finding. And as you saw, the IPV interventions were limited by heterogeneity in the populations and the outcomes that were reported, as well as the interventions. Next slide. So just to conclude, RCTs of screening in non-pregnant adult women did not show reduction in IPV exposure, improvement in other outcomes. There are screening tools that are available for practice that can identify women with past year IPV. most limit to non-pregnant populations, and the 2 that are evaluated specifically in pregnant populations had low sensitivity. Interventions for screen-detected IPV show inconsistent results. So there's evidence from 3 trials that show that home visiting interventions and behavioral counseling that address multiple risk factors may reduce IPV. Next slide. Finally, there are limited evidence about harms, and none of the studies that we included looked at the potential harms of screening via virtual visits. I didn't show this evidence due just to time, but we found no studies that looked at screening or treatment for abuse in older or vulnerable adults. There are 2 screening tools that we identified that look at a sort of abuse of older adults, but they come from very different populations and settings and are probably on the sort of edge of being feasible for use in primary care because they are longer than the sort of usual brief, able to sort of deliver in 10 minutes or less, sort of the time frame that we usually consider. And that's the end.
Thank you so much. And I hope everyone will join me in thanking Cindy for a fantastic presentation, really comprehensive. I, for one, actually really appreciated also the at the beginning, sort of your history of how things have evolved in terms of the populations included and all of that kind of stuff. And then also your comments at the end around the kind of emerging instruments. It really, I think, brings to life just how like living the journey is with respect to evidence for these kinds of topics. So let me tap our colleague April Joy and see if you want to share just a few minutes of your initial reactions to this presentation.
Yes, thanks, Elizabeth. And so glad to join all of you and really commend Cindy and your colleagues on very extensive report. So I read the 172 pages minus the references. And just for those who may be joining later, so I oversee the Weitzman Institute. We largely focus in the FQHC space nationally. So for those who are less familiar with federally qualified health centers, serve 32.5 million Americans annually. And that includes 1 in 10 people and 1 out of 8 children nationwide. And so with my first point, so FQHCs serve 3.8 million patients over the age of 65. So the first point I wanted to make, and Cindy brought this up in terms of the limitations of the report, is really that there's this need for greater research and guidance on how to screen for, prevent, and address elder abuse, right? So we know that the reports from the World Health Organization, as well as the U.S. Center on Elder Abuse, that the prevalence of elder abuse is quite high, right? Findings show that between 1 in 6 older adults experience abuse in a given year. We've seen that pre-pandemic, and then as a result, or during the pandemic, we saw an increase in that. It became 1 out of every 5 older adults experienced elder abuse during the COVID-19 pandemic. When you look at rates of abuse in nursing homes and long-term care facilities, which we've worked with in the past, shows that 2 out of 3 staff report having committed abuse in the past year, right? And so we know that risk factors such as social isolation, mental impairment such as dementia or Alzheimer's are 2 factors related to violence among the elderly. And the AHRQ also notes that annual losses incurred by older adults who are victims specifically of financial abuse total to over 28 billion each year. So really recognizing, and it'll come out more as you hear my comments in terms of my public health approach, given my training, that it's not just the impact on societal costs, elders and individuals themselves, but also families and caregivers, right? And the second point I want to highlight from Cindy and your colleagues from this report is really this need for more research on IPV screening and interventions for men, adolescents, young adults, LGBTQ populations, So we at the Weizmann Institute do a lot of work across gender, sexual orientation, across the life course. And, Cindy had brought this up in terms of, similar prevalence with men experiencing or sexual violence, physical violence, or stalking by an intimate partner. But it happens about in 1 out of every 3 men during their lifetime, right? And then so knowing that over half of this, or 56%, have their first experience of IPV before the age of 25, right? And so for me, who's really trained earlier in the life course, what does that mean for us who work with youth and adolescents for really understanding how to look at IPV as we look earlier in the life course, and not just intervention, but also prevention. And then the third piece, again, given my work, so my other hat, I'm the senior scholar in residence for health equity at Academy Health, but also faculty in the Department of Mental Health at Johns Hopkins. So really have focused a lot of my work in health equity and social determinants of health, and really want to drive home that point earlier in Cindy's slides of the socio-ecological model, right? Like understanding the socioeconomic root causes of IPV and why screening alone will not be effective, right? This is the big conundrum and challenge of screening for different health-related social needs and social determinants of health, right? So we understand, and I actually presented a lot of this during the pandemic, right? Imagine we were in a state of lockdowns and the challenges that came with the pandemic. So there's rich research on this, right? In terms of the role of socioeconomic risk factors playing a significant role in increasing the likelihood of IPV, right? We know that financial stress is an important risk factor, and that the connection between heightened levels of stress due to resource constraints, we know that conflicts over money, housing, basic needs. In my prior presentation, we talked about even access to PPE, and the lockdowns making it very challenging, right? Independent housing. And so just understanding the patient in front of you and how it may not be that easy to leave a violent relationship, right? Because in terms of stability, children being involved, access to legal assistance and other social services, and really understanding that leaving a violent relationship is not just a matter of walking out the door, but understanding that there's other challenges and resource and financial strengths that come with this, right? So we hear that actually close to 99% of all domestic violence cases coincide with economic hardship, right? And so understanding, and I'll come back to this in my later remarks, that connection between the socioeconomic risk factors and IPV, and what makes it so challenging for us on the provider side to be able to address these issues because of the web of factors that are associated with IPV.
Thank you so much, April Joy. Always a pleasure to get your perspective on these things, and also to hear a little bit more about sort of putting a little more color to how we think about these things in the context of specific individuals and specific subpopulations, as well as some of the more complex factors that one needs to factor into these sort of screening and post-screening interventions that need to be applied. All right, so without further ado, so we just, for folks who are tuning in and listening, this is another pitch and reminder to please be thinking about what kinds of questions you might have, both for the authors, as well as kind of for broader general discussion later in the conversation. We will be coming back and having further conversation with Cindy as well as with April Joy. But right now, what we're going to do is we're going to turn over to Amy Cantor and hear a presentation of that report focused on respectful maternity care.
Great, thanks so much for having me. I will start with our next slide. I'm going to be talking about our Respectful Maternity Care report. And first want to thank our funders and our research team. I also want to acknowledge the experts that we engaged with early in the process and throughout the report, including peer reviewers. And first wanted to just point out that throughout the presentation, we use the word women and mothers when referring to pregnant people or people who are pregnant or recently gave birth, but also acknowledge that not all people who become pregnant or give birth identify as women. So I wanted to point that out just ahead of our conversation today. Next, I want to focus on our objectives on the next slide. So today we're going to understand the history, context, and evolving attention towards respectful maternity care. Hopefully lots of people on this talk today have heard about this, but I'm hoping to share more of the things that we've learned leading up to and following this report. We're going to compare and contrast two primary frameworks for respectful maternity care that focus on disrespect and abuse, and then in contrast, but also somewhat in partnership, the rights-based framework. We're going to evaluate the current evidence on validated tools to measure respectful maternity care, and also importantly, identify critical gaps in the evidence that can affect US healthcare practice. Next slide. Our review focused on the US health system, and here you can see the most recent US data demonstrating the ongoing disparities in maternal mortality within the US. Many health inequities are experienced beyond these maternal mortality data, which amplify this problem. And while the number of maternal deaths in 2022 actually was lower than earlier years, primarily because there were fewer COVID-related maternal deaths, the US faces continuing challenges in reducing maternal mortality. These statistics illustrate that it's safer, I'm still here, yeah, to be pregnant and give birth than in all comparably resourced countries than it is in the US, with the greatest impact on Black women. So I want to highlight that disparity, that Black women continue to die from pregnancy and childbirth complications at unacceptably high rates. And US women overall are more likely to die from maternal complications than women in other high-income countries. So this most recent CDC data indicates that disparities between white and Black women are actually becoming worse. And we also recognize that disparities for Indigenous women who are not represented on this chart also exist. And the majority of deaths actually occur in the postpartum period. So from 1 day up to a year, but most of these statistics account for the first 42 days. All right, next slide, thanks. The US also has higher rates of severe maternal morbidity than in all comparable countries, and rates continue to increase with stark disparities in overall poor domestic maternal health outcomes. So maternal morbidity includes health conditions that are stemming from or worsened by pregnancy, and this is also in the rise and disproportionately affect people of color or those with social disadvantages. These conditions do not necessarily lead to death, but can have negative impact on quality of life that can last for months or even years. And these conditions lead to adverse outcomes for birthing people, may include cesarean delivery, stroke, adverse outcomes for their children, and suboptimal breastfeeding. Inequities in access to care and patients' experience of care are often rooted in discrimination and bias. And other data show that racial disparities exist both within hospitals and between hospitals for maternal morbidity. Next slide. The US maternal mortality rate has been on the rise in 2000. So here I am highlighting two countries that, in terms of populations, are relatively similar. Certainly not from a healthcare system standpoint, but in terms of populations. And the COVID pandemic challenged health systems across the world and certainly may have played a role in limiting women's access to healthcare. But for many years, poor US maternal health has been framed as a problem with individuals' health or choices. Frequent arguments were made about US women maybe being more obese or higher rates of smoking, possibly older, or any cause that might be inside someone's body or relate to their individual choices. But looking at these statistics, it sort of argues against that framework, where we don't believe that childbearing population in the US has actually changed so radically from the population in the UK over this time period. But these numbers point to systems level problems, not necessarily individual health or behavior problems. And while there is general agreement that clinicians have a moral and ethical obligation to treat birthing people with dignity and respect, there's emerging research that mistreatment during childbirth plays a prominent role in these disparities. Next slide. So I'd like to consider maternal health from this perspective and invite you to more carefully examine some of the macro level forces that contribute to current maternal health outcomes, including mistreatment and dismissal. So here I will borrow from the prolific Taylor Swift. And we think the problem is indeed us and the healthcare cultures and structures we have created and maintained, including how we understand and have also failed to understand respectful maternity care. So many studies on mistreatment, just to kind of set the stage, have focused on lower and middle income countries, but recent survey data reveals similar experiences in US women. There was a 2023 CDC survey of approximately 7,600 US women, and it revealed that approximately 1 in 5 women reported mistreatment during maternity care. So failure to listen or respond to concerns or symptoms of pregnant or birthing people is a key factor associated with increased risk for severe maternal illness or death. All right, so now I'm going to focus on our review here after setting the stage to kind of give everyone a sense of how we arrived. So our research team conducted an AHRQ funded systematic review to synthesize research for defining and measuring respectful maternity care, identifying the absence of respectful maternity care, also described as disrespect or abuse during childbirth, examine the effectiveness of strategies for implementing respectful maternity care on health outcomes, particularly for populations at risk for health disparities. And I know there's a focus today thinking about how certain populations are affected by certain services. And I would say that this particular report centers around issues of equity or inequity. And so you can kind of see in the subtitle here, dissemination and implementation of perinatal safety culture to improve equitable maternity health care delivery and outcomes. The next slide, I just want to acknowledge our research team again and highlight recent publications for anyone that wants to take a deeper dive, because this is going to be a very quick overview of our report and findings. But we do have the full review available, recently published just last month in the journal Birth, about the more history and evolution of seeking respectful maternity care. And of course, our paper that was published last year in the Annals of Internal Medicine. So I would invite anyone to take a deeper dive into those reports and publications. On the next slide, just the overview of our systematic review that synthesizes research for defining and measuring respectful maternity care and identifying its absence, examining the effectiveness of strategies for implementing respectful maternity care on health outcomes, particularly for those populations at risk for experiencing health disparities. And just to highlight that our key questions focused on effectiveness did not include lower and middle income countries, in order to focus on health systems most similar to the US. However, those countries were considered as part of a contextual question, which you'll hear more about in a few minutes. And this was all part of a federal initiative to improve person-centered and equitable care for birthing people. Next slide. Studies included for the contextual question were source documents defining formative frameworks and were organized categorically to identify aims and components of respectful maternity care. Our summary of these frameworks is not meant to be comprehensive or exhaustive, actually more comprehensive and less exhaustive, but provides context for how studies that frame respectful maternity care help evaluate the impact of interventions across diverse populations. And we recognize that there are additional movements and frameworks outside this data set that could be included as guidance for future research. So I'm trying to really cover this timeline, as you'll see on the next slide, to understand the history and context that influenced the prior and contemporary understanding of respectful maternity care. And this has evolved greatly over the past 100 years and is shaped by scholarly, clinical, community standards, which may include religion, human rights, government, public health, midwifery, ethics, activism, and the law. On the next slide, we're going to take just a little bit of a closer look on that history. Next slide, please. Where you can see that early efforts to understand respectful maternity care included language focused on defining non-respectful maternity care through the lens of disrespect and abuse. And those, again, were considered more in lower and middle income countries. And later you can see how these frameworks center more around rights and freedom. So if you look at this timeline, we're aiming to depict roughly 100 years of birthing practices. So briefly, this began with managing labor, where you're thinking about cultural and healthcare changes in North America and Europe. And in the 1930s, the movement for humanization of childbirth that ultimately undermined longstanding biblically grounded ideas that labor and pain and suffering were part of a divine plan to punish women for original sin. And this movement expanded attention from eliminating birth pain to advancing humanism during labor and birth. And early leaders on these topics initially lauded opportunities to hasten birth, like using forceps, or erasing the memory of labor pain using obstetric anesthesia as the correct approach to humanizing birth. And this advanced the value of managing labor and twilight sleep. But later in the Belmont report, they articulated in the report more ethical and moral requirements to center individual autonomy. And so as you see what happened, what emerged from there was a focus on autonomy in regard to humanizing birth and rejecting that twilight sleep. So we shifted then to the role of midwives in birth support and attending labor, where there was wider value of autonomy and agency, new ideas about the causes of pain and suffering, and contemporary articulations with midwifery approaches to care. And these influenced ultimately revise our understanding of humanizing birth and a wider application of human rights and women's lives, and what was then emerging as the concept of reproductive justice. So then we shift to the past 20 or so years, where there's a focus on respectful maternity care, which incorporated shared decision-making and person and patient-centered frameworks. And over the past nearly 20 years, there has been an upswell in interest of respectful maternity care, particularly in clinical, ethical, human rights, and anti-racism efforts. And although respectful maternity care has been more widely studied in lower resource countries, there's now a concerted effort to examine this within higher resource countries. And we'll see a few of those initiatives later in this talk. And so part of this is efforts to create metrics in global health, which are now shaping how we create metrics in US health. And so what we're seeing throughout the scholarship is calling out the necessary but imperfect process of health outcomes definition and measurement. So now we're going to dive into some of that. So our key questions help guide the research, which also included an analytic framework. And our work was defined by 4 key questions addressing respectful maternity care components, validated tools and measures, and effectiveness, as well as how effectiveness and harms may differ by patient characteristics and non-patient factors. So in the next slide, just briefly, is an overview of our study eligibility criteria. You're all familiar with PCOT's elements, but essentially having transparency in our methods included using this predefined eligibility criteria to limit the risk of bias in our review process. And although we acknowledge opportunities for the delivery and receipt of both disrespectful and respectful care throughout the prenatal period, this review focused just on this window of labor and delivery and immediately postpartum. Next slide. After review of over 4,000 abstracts and over 400 full text papers, we identified 37 studies to include. There were 2 main respectful maternity care frameworks, 2 central frameworks that describe categories, which we described as domains or components, that served as a set of indicators to guide recognition of either disrespect and abuse in facilities, and also inform the recognition of mistreatment during birth. For our contextual question, we used a descriptive approach to provide a qualitative summary of components in those 2 sets of frameworks. And the 2 main frameworks are organized by those themes and components. For key question 1, we used COSMIN criteria or consensus-based standards for the selection of health measurement instruments to facilitate general descriptions of specific aspects of measurement validation. And so we used certain elements to assess the validated tools using specific criteria, and also considered sampling and population characteristics. So many of these validated tools were applied in a variety of countries and settings, and ultimately in our discussion made sure to highlight those that were most applicable to US settings. We also created tables to summarize psychometric properties of validated tools to measure respectful maternity care or maternity care experiences that use some of those RMC elements. And we have summary tables for those findings as well. For key question 2, there were no studies. And for the third question about the effectiveness of respectful maternity care, there was one study that reported reduced rates of postpartum depression among interventions versus controls, and that was in Iran. Next, want to really highlight these 2 frameworks. So I have mentioned a couple of times the disrespect and abuse versus the rights-based frameworks. And there were 12 studies that described 12 influential and recent frameworks showing 2 key approaches. And the first approach is based on 2 central frameworks that describe categories, so domains, components that serve as a set of indicators to guide the recognition of disrespect and abuse in facilities and inform the recognition of mistreatment during childbirth. So you can see some of those main themes that emerged there. And then shifting to the rights-based approach, those emerged actually in response to disrespect and abuse frameworks. And they specifically articulate that RMC is not simply the absence of disrespect and abuse, but also incorporates aspects of reproductive justice, excuse me, human rights, social justice, and anti-racism. And this is also described as freedom from bias and discrimination by some of these frameworks. And these frameworks consider influences of the wider social constructs and systems, and they center on wellness and thriving rather than exclusively on issues of abuse and disrespect. And so we summarize these overlapping components by each of these frameworks through broader themes to help characterize these components. And as I mentioned, reviewing these definitions and frameworks is not meant to be exhaustive, but really helps provide context for how we can frame RMC to then evaluate the impact of interventions across diverse populations. Next slide. So I pulled this table out of our Annals publication, which summarizes contemporary RMC rights-based frameworks that use terminology around rights and freedom to describe RMC. So you can see the different frameworks represented by groups that have brought these frameworks into their practice or into their organizations. And what we did was kind of map out essentially what components are recognized in each of those frameworks. So there is quite a bit of overlap. And we summarize the 10 rights-based frameworks with those overlapping categories to summarize contemporary RMC frameworks using similar terminology. Next slide. We also created a conceptual diagram for the contextual question that was based on a synthesis of concepts and themes that were described in these frameworks, and also along with input from clinical content experts, topic experts, and advocates on how well these concepts were represented. So this contextual diagram illustrates the multifaceted dimensions of respectful maternity care. I think similar to the last presentation, we saw that there's a lot of overlap and a lot of complexity into how you kind of arrive at this patient experience of respectful maternity care. We wanted to highlight that this really centers around the patient experience with care, but there's this big arc of levels of influence, essentially, that impact how respectful care is delivered and experienced, and then ultimately how this affects clinical health outcomes and maternal, infant, and patient-reported outcomes. So there's along the bottom this pathway of respectful maternity care, but also understand that there are these multiple levels of influence that affect that experience, and really want to remind everyone that we're really trying to focus on the patient's experience of care. And these influences are affected by access to care, which may include geographic considerations, travel, insurance, issues of equity like race and ethnicity, gender, age, culture that may affect patient, family, and clinician relationships, concepts of consent related to care decisions, procedures, and interventions, and autonomy, which includes patient choice, shared decision-making. And so all of these ultimately represent little inflection points that might give rise to disrespectful care, with additional barriers for populations who historically or currently experience health disparities. Next slide. This table summarizes the 12 validated tools we use to measure respectful maternity care. To highlight how each tool functions across these specific domains, tools are organized into those that directly measure respectful maternity care and those that include components, but were not designed to specifically measure RMC. And of the 12 tools that were evaluated in 24 psychometric assessment studies. 8 were specifically intended to measure RMC, and 4 other tools included concepts or questions related to those. So those may include consent and autonomy, dignity and respect, communication, information exchange. And among those validation studies, they also were provided to evaluate either current or prior birth experiences. And some of these surveys were given during pregnancy or the postpartum setting. So all of those details can be found in these tables and also in our report. But in the interest of time, I will move through our results. Next slide, please. Through careful consideration of the history and concepts within the frameworks and their overlap, we also developed a definition with input from clinical and content experts. So specifically, we define respectful maternity care as an approach to maternity care that honors the dignity, personhood, autonomy, and interests of birthing people, prevents disrespect, mistreatment, or abuse toward individuals who are using maternal care services, and provides a practical paradigm for the delivery and receipt of peripartum care through a rights and reproductive justice-based framework. And so here you can see these standard elements of respectful care that really emerged out of this synthesis of these frameworks and of these tools. So really we tried to pull forward all of these overlapping themes centering around the birthing person that includes communication and shared decision-making, and also includes safety and justice. Next slide. So I shift to the gaps in the next steps, because I think a big question is, should we be measuring respectful maternity care, and how should we be measuring it? And gaps in the evidence present challenges with varying terminology and framing. So there's some important implementation factors and issues that can be further refined with patient feedback and additional evaluation before broader implementation. We also learned that we have to consider the impact of obstetric emergencies and traumatic birth experiences and the impact of care transitions. So thinking about, where does policy meet research? There are longstanding and multidisciplinary research on the concept of RMC, but this should then catalyze wider instrument development or evaluation to then promote careful consideration of future work to define and test the effect of these strategies to then deliver RMC. So we'll need to think about implementation and translation into effective programs, care bundles, safety bundles, and QI projects. And still, again, to highlight that there needs to still be consensus around a definition of respectful maternity care and metrics, since there currently is no gold standard. Moving forward, we might want to think about how our training and values influence how we interpret respectful maternity care and patient-centered care. Next slide. I know I'm short on time, so I'm going to just wrap it up here. Ongoing efforts to understand the effect of respectful maternity care on the U.S. maternal health situation, including inequities, really highlight this need for further research. So I just wanted to highlight here that now, stepping beyond the evidence review, there is ongoing evaluation on the impact of an application of these, specifically in AIM, which is the Alliance for Innovation on Maternal Health. They have incorporated the 5th R, so respectful maternity care, into patient safety bundles, which are a structured way of improving processes of care and patient outcomes. And these are collections of evidence-based informed practices to develop clinically specific goals and measures for specific conditions. So the 5th R, which is part of readiness, recognition, prevention, response, reporting, now includes respectful, equitable, and supportive care. USAID and MCHIP also have created toolkits for health systems and for clinicians designed to begin implementation of respectful maternity care. The California Maternal Quality Care Collaborative has considered RMC as a way to inform protocols for safe and respectful hospital transfers. So this conversation is ongoing, and there's lots of work that's happening and that may occur to really move this whole respectful maternity care, I would say, movement forward. On the next slide, I just wanted to remind everyone that these frameworks are well described, but they do vary in their definitions. Have tools to measure respectful maternity care, and they demonstrate consistency, but really lack a gold standard. So we need further evaluation before widespread implementation in US settings. And that evidence is lacking on the effectiveness of implementing respectful maternity care to improve any maternal or infant health outcome. So thank you for your attention. You'll see on the last slide just some proposed solutions and some links for things that are ongoing in different organizations and agencies. And I'm looking forward to questions and our conversation. So sorry I went over time. A lot to cover.
You did not go over time. Look at you coming in right on time. Good work.
Oh, great. Perfect.
Yeah. Don't worry. So I hope everyone will join me in thanking Amy for our second fantastic presentation that we've had today. And I'll just admit, because I'm a nerd, I love a good framework. And so I really appreciated the work that you did in the presentation today to really ground a lot, you and your colleagues, to really ground a lot of the evidence work that you were doing in some sort of mapping of a couple of different conceptual frameworks together. So kudos to you all for that. I think before we sort of have some broader discussion, I want to turn to April Joy to get some initial reactions to this report.
Yes, thanks, Elizabeth. And yeah, thank you, Amy. I echo Elizabeth's sentiments. Such a thorough background, including on the history. Rather than make 3 points for my remarks for this one, I just want to make one main point that I really saw from the report, that our understanding of respectful maternity care, or I'll use the same acronym, maybe use it RMC, is really based mostly on applications in low and middle income countries, and really recognizing the significance and relevance of what Amy laid out beautifully and thoroughly in terms of addressing maternal disparities, including obstetric violence in the US, right? So Amy made a great point. US, you saw that huge bar on the far right of one of our slides in terms of the US having the highest maternal mortality rate of all industrialized nations. And even if the majority of maternal infant deaths in the US are preventable, right? We see that even higher specifically for Black mothers, right? And Black birthing people. And yet there are no trials from the US or US settings applicable in evaluating the effectiveness of RMC for any health, utilization, or patient reported outcome. And it's not often that I get to talk about or share a narrative about Beyonce in these settings. So I will use this time because I think it's important, in addition to the statistics, of knowing that these are real people's lives and humanizing the topic. So I'm actually taking from the work of doctors Davis, Casper, Hammonds, and Post, who really talked about and used the example not just of Serena Williams, but also Beyonce's just really traumatic birthing experience. So actually Beyonce had talked about this issue of obstetric violence in her interview with Vogue, really shedding light on the harmful practices with the healthcare system that exists even at elite hospitals and that transcend economic barriers, right? Because sometimes race, ethnicity is, or I should say some have thought that economic status is a proxy for race, ethnicity. And I just really appreciate, Amy, you calling out racism and the history and that legacy that continues to impact the disparities that we see today, right? And so Beyonce, in that interview in Vogue, talked about the intense and difficult childbirth experience she had that involved toxemia, an emergency C-section, knowing that the lives of her twins were at risk, and that even with her status and access to what many assume would be the best medical care available, knowing and learning about her emotional and physical trauma, knowing that this is a reality faced by many Black women, regardless of their socioeconomic status, right? And so Beyonce, in her own words, right, because we also want to think about the patient's narrative, she said, "I was in survival mode and did not grasp it until months later." She notes that there were pregnancy complications and the pressures of postpartum recovery, revealing the systemic shortcomings, which Amy had talked about, and potential biases in maternity care. And so really acknowledging the importance of RMC, right? So doctors Davis, Casper, Hammonds, and Post note that this is not just a history of individual physicians lacking in attempts to provide compassionate care or simple mistreatment of their patients, right? So in legal terms, it's not just a matter of bad actors or bad apples in healthcare, right? So knowing that it's a history that shows persistence of systemic racism in medicine and how it accounts for the chronically high maternal morbidity and mortality rate of Black women. Yet these disparities have become so normalized that it's difficult for some analysts, researchers, and practitioners to see how racism continues to shape power relations between institutions, actors, and their health consequences. They note that historians of medicine have charted how Black people were isolated and removed from the world of health and locked within a prison of sickness over the course of the 20th century. So really recognizing the complexities and the ongoing legacy and present day of racism and its impact on violence and harm towards maternal health, women of color, and particularly Black women in the US really highlights the importance of what it means to look at RMC within the US healthcare context.
Thank you so much, April Joy. That was a powerful reflection. And I think there are some comments coming through in the chat as well that are reflecting a little bit on some insights coming out of the report. And so just wanted to give a shout out there. So I'm going to turn things over to Lucy, because I think what we want to do now is have some discussion with the report authors and make sure that also we're coming to all of you who have joined us today. And so if you all, this is another shout out for you all to put any questions that you have in the chat, so we make sure that we are elevating those and that those questions are being brought to our report authors as well. But in the meantime, I'm going to turn things over to Lucy.
Thank you, Elizabeth. And thank you, Cindy and Amy. Wonderful reports. And April Joy, just excellent discussion. So now we've heard from Taylor Swift and Beyonce. My day is complete. I'm going to ask Keisha Lockhart to just comment on what she's been sort of posting in the chat, because she feels very apparently passionate about it. And I think she's got some insights. Keisha, do you want to come on speaker and discuss what the points you're trying to make in the chat? Keisha, are you there? You have to unmute yourself.
Until Keisha comes on, I did want to highlight that she is pointing out some specific work in the area of Dr. Karen Scott and things centering around obstetric racism and obstetric violence. And we talk about that in our discussion, particularly to highlight that this is emerging literature, and there actually are some of the tools that we incorporated into our review that is part of that work. So the patient-centered maternity care tool, as well as some that emerged from those that Keisha mentioned, are really important frameworks in grounding where the gaps are and also highlighting specific issues in populations in the US. So certainly would invite folks to bring it up in discussion today or take another look there so we can think about these gaps and sort of where we're headed. Issues of racism and obstetric violence and trauma are really complex and have a lot of issues, whether it's social determinants of health or deep-rooted biases and racism in the US health system and just in the US in general. And so thinking about how we kind of lean into respect for maternity care and respect all patients, this includes consent, right? So we kind of heard a little bit about that I think that patients in general, anyone who's on this call who's either witnessed or experienced childbirth, probably realize that it's not on the day that it's happening what you think it might have been. So with that comes the birth support and the guidance and the consent, because in the moment, maybe clinicians or health systems have to think about pivoting, and when there are interventions that need to happen, how do you explain that to a patient and honor their preferences? So there's a lot in the balance there that I think really present opportunities for improving respectful care.
That's very helpful. Thank you. And Keisha's having difficulties with her audio. So I encourage everybody to take a look at the comments she's been making and the points from her perspective as a midwife and peds nurse practitioner. So thank you. Why don't I start with Amy's report first, just because we'll do it in the order that you heard it most recently, and then we'll turn back to Cindy's report. So again, you're welcome to chat questions that you have for these authors in the chat. I'm going to start off with just a couple of questions that I have prepared in advance with the authors. So I'm just wondering, Amy, how do you suggest researchers address the lack of US-based trials assessing respectful maternity care's effectiveness, and what aspects of the international findings, such as impact on postpartum depression, do you think could be transferable and relevant to care here in the US?
I think the gap here is the implementation piece, because we do have some really helpful frameworks. We have tools that, generally do a good job at measuring these important elements of respectful care. And I would say there's a lot of overlap in how we agree upon, what we are meaning when we talk about respectful care. So the next phase is to look towards some of the organizations that are implementing these quality care initiatives. And there are quite a few, both nationally and in certain states. And support them to be able to measure outcomes. Historically, when we look at some of the data, or even we look at implementation research, I recently did a separate study looking at barriers and facilitators to clinical preventive services and delivery of care. And so thinking about, asking these systems and also individual clinicians, what are the barriers to actually delivering this care, and also patient perspective. So I think there's lots of ways to identify better ways to implement this, but we also have to know how to measure it. And one of the barriers was the lack of metrics, and also, payment or HEDIS measures that sort of incentivize systems to wanting to evaluate and measure those things. So how do we then incorporate implementation and ultimately measuring important clinical outcomes? And I think what we have to do is make the leap and partner with our qualitative researchers and our quality initiative groups to then look at outcomes measurements, so we can standardize care, standardize measures, and look across health systems to have some sort of standard implementation to then measure outcomes in the same way.
That's very helpful. I'm just wondering, though, as I posed the question, we talked about randomized trials. And then you mentioned the fact that you did some qualitative research. A lot of that is not included in randomized controlled trials as they get reported. Are you suggesting that there are other types of study designs that might be useful to help us understand implementation and adoption better?
Absolutely. I think implementation, there's some flexibility there. I mean, ideally, randomized trials were really designed to measure the effect of drugs, right? Like one drug versus the other drug, there's a placebo. Now, in a lot of these contexts, and especially when we're looking at pediatric and maternity care research, there's ethical questions on whether or not you're going to randomize someone to not receiving respectful care in particular, right? But you can certainly look at non-randomized studies, or you can look at more qualitative or observational data in terms of, shifting approaches to care. And if the measurement outcomes are the same, perhaps just looking at the, a hospital or a system or a state that implemented a quality care initiative, and then one that didn't, and are those outcomes different, where there's an awareness and there's a direct plan to then implement a standard of care, where, otherwise we kind of see what's happening when it's not implemented, and it's not really good. So I think we have a lot of opportunities to change how healthcare is delivered, and then also, as long as we can standardize that measurement, we have a helpful comparison as well.
And do you think the location of the birth process is a contributing factor? Like, is the birth done at home versus in a birthing facility versus a hospital, which you get more medicalized?
Yeah, I think that's a great question. Our review did not look at home births or birth centers necessarily. I did actually present this work to the California Maternal Quality Care Collaborative, and it was specifically to inform hospital transfers. So it was actually looking at how can you implement RMC in the context of transferring from a home birth to a hospital. And so hospitals can be when they receive the patient, how do you make sure that that patient is cared for in a respectful way? So there's lots of opportunities there. I think we don't have the data yet, but there are potential partnerships. And certainly during COVID, we saw a big increase in home births, and that may have been because of fear or because, pregnant people were not comfortable, or they were worried about how they were going to be treated, or their partners weren't able to be there. So it's very interesting to see kind of that patient response to where they're choosing to give birth or, deliver. Other deliveries. So I think these are all just important questions to put out there and opportunities to evaluate, if patient experience of respectful care is different based on where they deliver and how. So these are really great questions.
Right. And I love the socio-technical sort of ecosystem approach that both authors used, but I think also going back to Donna Bedian and structure, process, and outcomes, looking at the setting and the characteristics of the setting that influence the implementation. I see that, Angel, do you want to come on and ask your question? You're on Christine's computer, if that helps identify you.
There we go.
There you go.
Can you hear me?
Yes.
Sort of. Okay. Yeah, I was just wondering, I noticed in both the frameworks you presented, as well as the sort of collapsed definition, that the sort of positive aspects of actually being respectful were much more conceptual and vague. And, the absence of abuse and trauma is hopefully a little easier to know what that looks like. And I was wondering, both in the interventions you came across or as you were looking at interventions, was there an ability to sort of operationalize some of those concepts so that it's a little easier to see if it's happening?
Absolutely. The rights-based frameworks actually focus more on the receipt of respectful care, if their choices were respected, if they felt like their privacy and confidentiality were respected or considered. Certainly, it is easier to measure the absence of abuse or the absence of something harmful. But a lot of those tools do aim to measure those positive aspects as well. And we reflected that in our definition, that thinking about measuring, was there consent for your forceps delivery? Was there consent for your cesarean section? Those are the types of questions. Now, we had one study of implementation, so I have to say that we don't have this in the data, but backing upstream a little bit in terms of the tools that aim to assess that there are many tools that incorporate some of those positive aspects in terms of what you could measure from patient experiences.
That's great. Thank you.
And the report includes those various tools. I haven't read the report myself.
Did you hear that, Amy?
No.
Amy, did you hear what?
I didn't. Could you repeat the question or type it into the chat?
I was asking if those tools are contained in the report.
Oh, yeah, definitely. I'm happy to share which tables. Also, those tools are highlighted in the shorter manuscript in Annals, and so those elements are all in there. But if you really want to get into more details of each of the tools, those are all available in the appendices as well.
Great, thank you. We're running a little bit over time. Thank you very much, Angela. We're running a little bit over time, so I'm going to turn our attention back to Cindy's report on intimate partner violence. So please, chat in your questions as we're moving forward. But I'm just wondering, what we were talking about with Amy, Cindy, were there still issues around, knowledge and information about implementation and adoption of screening tools for intimate partner violence that you uncovered in your review?
I think that what I realized was more of a gap in terms of what the current evidence is and what is happening in terms of primary care practice, partly driven by COVID. So, I mean, I do think we need to understand like what the barriers are from like the practice or system perspective of screening women for IPV, and to what extent, you know, the issue of thinking about, you know, virtual visits or other factors might be in the way. I also think that we need to be sort of aware that coercive tactics associated with IPV may include tactics such as having access to an electronic medical record, for example, and being able to look at information that's there. And so I don't think that, I don't have the answer for that, but it certainly didn't come up in any of the evidence that we had for the review. But I do think it's a really important thing to think about with implementation, but also is really important to think about with designing, you know, new studies that focus on screening for IPV or interventions for IPV.
Right. And so, you know, one of the comments that Elizabeth made in the chat was she really talked about, you know, this cross-cutting issue in both reports about the opportunity to be thinking about honoring the preferences and autonomy of patients. What you know, do you sort of discern from the synthesis that you did in terms of understanding those kinds of issues and like willingness to report and disclose, living in such a situation?
Yeah, I think it's really important for this topic. I think that this definitely came up with one of our really thoughtful peer reviewers, but basically the comment from one of our peer reviewers sort of as an overall kind of, you know, what do we do next in terms of addressing this problem was like, we really need to find out from the perspective of women about what they want, like, or what they need from primary care providers related to IPV. You know, it's a problem that potentially doesn't always need the healthcare system. There are community resources. You know, women are resilient. They may sort of rely on support from friends and family. And also there's the potential to be, I mean, I'm not like to cause harm, but you could respond in a way that really makes the assumption that the person just doesn't know, or any, like that it's just like, why don't you just leave? And so having a better understanding about like in what screening modality might be sort of, you know, more acceptable to women, but also thinking about like how, what sort of response would be most helpful, because as you can see, like there are such a wide variety of intervention types. And I don't think that I mean, we certainly looked for some of that information to inform the introduction and discussion. And I think that's a real gap in terms of like having a better understanding of, you know, meeting the needs of people who are affected by IPV.
Good point. Christina Osmond, do you want to come on and ask your, or make your statement, an observation?
Yeah, no, it was just a comment that some, unfortunately, and I know.
Can you speak up a little bit so the author can hear you?
So one thing I think that has come up in a few communities that I am familiar to is that some people may not realize that what they're experiencing is IPV. And I think, you know, there is unfortunately still some conversation that like, oh, well, if it's not physical violence, then it's not an abusive relationship or a violent relationship. They may not recognize some of the signs. And so and they may not recognize the degree and the depth of the controlling behaviors that the other person is taking. So they may not realize that they need to necessarily ask for help at all, or maybe they just feel like it's a, you know, oh, this is a temporary frustration. Oh, we're in a fight, but not fully understand like, no, this is actually something very serious that you do need support with. And then getting that support, often the challenges that they're running into is they don't have a safe space to go, right? And so it's like, well, I like, especially with the cost of living right now, what it is in a lot of areas, you know, like having safe housing in that immediate effort to leave, and also being concerned about violent repercussions if they are found are two very large concerns that I think there needs to be maybe more effort to create interventions that can support in that way.
Yeah, those are really good points. One thing that comment reminds me to sort of say is that, screening is always going to be a limited intervention, right, for addressing the problem as a whole. The Community Preventive Services Task Force does have a recommendation around interventions that sort of focus on primary prevention, meaning primary prevention both of like victimization and perpetration, that kind of teach healthy relationship skills. So I think that's incredibly important, particularly as a mother of a daughter who started college, like to think about like what do we need to do to sort of make sure that people understand these coercive tactics and are aware of the problem. And I think, thinking broadly about primary prevention, particularly, younger people is very important. I also think that partly being sure that we are educating, providers about the problem is really helpful, because I think that, even either through conversation or just signs, being able to sort of address this and sort of say, look, I'm concerned because here are some things I'm seeing or that you've told me about the relationship, and I'm worried about you. So I think that thinking broadly beyond screening is really important in addressing some of the issue that you brought up.
Great, thank you. And Christina, do you want to comment on the chat that you just entered?
Sorry, the other comment was just that, like, one of the things that I think is starting to come out now, there's starting to be more books about it, and more kind of online resources for parents too, is having those early healthy relationship conversations and having consent conversations really early. And I think that's something that, in the, like, having that be a big part of our implementation, so that people are more aware of what's the healthy relationship, so it's easier for them to spot the unhealthy relationship even from when they're in middle school. Like, okay, why does your boyfriend or girlfriend in sophomore year high school need to have the password to your phone? Like, that doesn't make sense, kind of thing. Yeah, sorry.
No apologies. I just think, you're taking a public health view as we move into primary prevention, and then where would those conversations take place? Is that in, health education classes in the school system? Is it, family dialogues? So I think there are a lot of issues here to think about when we think about primary versus secondary detection. And let me finish up with a question for you so we can move on to the reactions portion from Amy, Joy, and Elizabeth. Cindy, what gaps in the current evidence were most surprising to you, and how do you believe filling these gaps, such as the screening tool accuracy or tailored interventions, could alter the approach to IPV screening and clinical practice?
Yeah, I think, some of our conversation, I think, has highlighted some of the gaps around the extent to which we have information on the perspective of the people we're caring for, or have fully implemented what we know may be barriers. But I think one key thing to point out, because it's really, I think, a key to thinking about the sort of screening framework, is that there isn't a screening trial that specifically targets pregnant people and includes interventions that address some barriers to ending or leaving an abusive relationship. And so I think that's really sort of valuable and would kind of address a gap in this evidence. It also, another thing that I guess it's not so surprising, because we did the previous review, but it, at this point, it occurs to me that these trials that show benefit are kind of dated in some ways. And I do think that to be relative to the current practice context, like, I think, additional studies that enroll screen detected women and look at interventions that include components that again, would sort of help with the barriers to leaving or resolving violence are really key. Just as an example, one of the studies that showed benefit around screening for multiple risk factors was published before there was sort of a recommendation on routine screening for depression. And it also includes a population where a large % of women in that trial were smoking. And so it's really not clear whether it was the intervention targeted to smoking or the IPV intervention that led to some of the benefit for birth outcomes. So I think thinking about, our current practice context and like understanding what interventions might be most effective for IPV and thinking about what we know now also about, barriers. I think those factors really do need to be addressed by future studies because I think as time goes on, these studies that found benefit there may be other reasons why they're less and less relevant to current practice.
Great points. Thank you. Well, at this point, I'm going to turn it over to Elizabeth and April Joy to discuss our thematic focus and how these particular reports can have an impact. Elizabeth, April Joy.
Thank you so much. And that was just a fantastic and really rich discussion. I was just loving, I think, as you can probably tell from the things I was putting in the chat, which is where I love to live. But it was wonderful to be a fly on the wall for a lot of that. So I want to dig in a little bit with April Joy to a few of the points that kind of came out of what we were looking at earlier. And so, I'm going to state the obvious a little bit here, which is, as we do these kinds of systematic reviews, the challenge that we often face is the heterogeneity of the evidence landscape, and that we sometimes are in this world where we're kind of destined to create this like thousands of puzzle pieces that will never fit together because of the way that our evidence landscape works. And so sometimes we really grapple with, what do we know and what do we not know, and what can we, who are the populations we can do something about, and where do we need more information, and all of those kinds of things. And so I'm going to start with, in talking with you, April Joy, about the IPV report, but want to ask you to reflect a little bit on, how does the heterogeneity in study populations and outcomes that we saw affect the ability to draw conclusions about the effectiveness of intimate partner violence screenings across different demographic subgroups? And when we think about that, what steps can we take to improve representation and relevance in future studies?
Yeah, thanks, Elizabeth. I appreciate this question, especially as a researcher who works with clinicians, but I'm not a clinician myself because I get this question often, right? Of like, if it's not relevant or not significant, then why are you showing me this study? And so I really think the onus is on us as health services researchers to really self-reflect and see how do we do better to that question you asked about representation and relevance. So a few points that want to bring up that we've learned through our work at the Weizmann Institute, particularly given the marginalized and vulnerable populations we directly interface with, not just in the clinical setting, but also research. We really want to bring home the importance of community engagement. So we know that there's a lot of evidence that points to community engagement as emerging as one of the most effective ways to recruit marginalized and vulnerable populations in studies, right? And so knowing that community engagement doesn't happen overnight, right? It really requires that upfront investment of time and resources, really spending time to learn about the needs of the community and invest resources, right? So it's not just me helicoptering into a community, getting my data, enforcing my specific aims, coming out, publishing my paper and presenting at an Academy Health conference, right? But really understanding how can this be co-developed, co-led, co-disseminated with those who stand to hopefully benefit from our research, right? Knowing that these mutually beneficial relationships can be leveraged not just for the current studies, but also for future engagement in clinical trials and other studies. The second point I want to drive is the importance of flexibility, right? Sometimes we have our recruitment protocols are dictated by the duration of a grant cycle. And then after that, it's like, if you don't meet this criteria, you can't fill in your informed consent form by this, ergo you are not able to engage in our study. And so really knowing that that flexibility is key, particularly when you're trying to obtain informed consent during the workday when your potential participants might actually also be at work themselves, and not everyone is able to work in a remote environment. The third piece, which we didn't talk as much today about, is access. And so what I've learned through our work, we've started to do more work with rural populations, and we haven't really talked about rurality as a barrier, not just in terms of IPV, but also maternal health. And so research generally tends to be clustered in urban areas and around large academic medical centers, right? And so what does that mean for our rural patients and families who do not have easy physical access to study sites, study visits, and follow-ups? And so how are we making sure that those populations also have access, even when they are not necessarily as quote unquote conveniently located near us, right? The last piece I want to share is for a researcher like myself, a health equity researcher, coming into an institution and knowing what is the reputation of your institution within the local community, right? And so having been trained at Harvard and Hopkins and knowing these institutions' relationships with the local communities was really helpful, so that I wasn't just coming in and saying, but I'm a health equity researcher, I've been doing this, yet I represent larger institutions that may not have had the best reputation or history of engagement with the local populations. And so what does that mean in terms of rebuilding that trust and overcoming or rebuilding the trustworthiness of our institutions that we now represent?
Thank you. That was fantastic. And I love the sort of pulling in of trustworthiness at the end. I think a lot of emphasis oftentimes is placed on trust, which usually places the burden on the other folks, right? Like the research participants, patients, those folks engaging in either the care or the research activities, rather than those who are sort of conducting those activities. And the other thing I kind of heard through that, particularly in the engagement piece, but I don't know that you said it so directly, was the importance of making sure that researchers are returning value to the folks that are being engaged, and the importance in being able to do that and have those feedback loops. And part of that factors back into that trustworthiness, and also that community engagement piece. So another question that I'd like to ask is, in thinking about, and you saw a lot of this discussion coming in the chat, so this will build off nicely off of some of those comments as well. But how can IPV screening programs be adapted in a way that minimizes risk for populations more vulnerable to those harms? And what equity-focused strategies might be considered to mitigate unintended consequences of screening?
Yeah, no, thank you for that question. So just some considerations that we've learned in our own work with working with health centers across the country, but also our own in Connecticut. One is sensitive and confidential screening process, right? So before my current work, I actually worked in trauma-informed care. And that was my whole dissertation on SAMHSA's trauma-informed care framework. So I see a lot of overlap in terms of the reports, and also understanding, to your question, Elizabeth, about mitigating unintended consequences, right? Ensuring privacy and use of respectful language when asking these questions, right? Like space is so important and words matter, right? And so having worked with victims who actually call survivors of IPV, they might be hesitant to disclose abuse due to fear of judgment, disbelief, potential negative consequences that I shared earlier, right? Because the potential financial dependence or economic control. And so when the screening process is not handled sensitively and there's not a lot of privacy, then it actually can shut down that lines of communications and actually do more harm than good. The second piece I want to share is thorough training for healthcare providers. I cannot emphasize enough the thorough piece enough, right? And so how do we make sure that our healthcare staff, and I would say not just clinicians, but often with us when working with team-based care, it's medical assistants, other members of the healthcare team who are asking the questions, may feel uncomfortable discussing IPV. I've learned some of them themselves may be victims or survivors of IPV. And so how are we supporting and equipping our own healthcare staff to ask these questions? Because we've found that when that training doesn't exist, it can lead to inadequate screening or missed opportunities, right? They'll just skip those questions because they already have a gazillion other questions to ask from other screeners that are involved with the intake, right? And so how do we make sure that our staff are properly trained and supported to do these screenings? The third piece I'll say is clear communication and support. I think explaining to patients, not just jumping into the questions, but explaining the purpose of the screening and also providing available resources and the steps of how that information will be used, right? Sometimes we've heard patients are afraid that it might be disclosed to their perpetrator of violence. And so what does it mean to really have that sense of transparency with patients of how information that they share will be respected and protected? And the last piece I'll say, we live in a very fragmented, not just healthcare system, but also ecosystem. And a lot is put on our healthcare staff and healthcare systems, but what does it mean to collaborate with community agencies, right? For us, we work a lot with local domestic violence shelters and advocacy organizations. To your point earlier, Elizabeth, about the importance of trust, and these organizations may actually have more trust than healthcare systems in the local community, right? And so what does that vertical and horizontal coordination look like, right? Not just healthcare systems or community-based organizations, but also child welfare, juvenile justice, law enforcement, the courts, education systems, housing, public health we've talked about, right? These are all essential aspects of the ecosystem's response to addressing IPV, and to make sure that it's really coordinated and not just the onus being on healthcare providers or those on the front lines within the healthcare system.
Great, thank you. I'm actually seeing a question come through in the chat, and it makes me think it might be good to sort of think about this from a couple of different perspectives. So Ellen raised a question in the chat. Can someone comment on strategies for accomplishing this screening given the intense time constraints of face-to-face clinical visits? In particular, thinking about the challenge of adding these screenings to the 10 to 15 minute prenatal care visits. And so this really becomes a question for, I think there are a couple of layers to this question, really, which is there's kind of the logistical challenge to this, right? Like how do you fit this into folks that are challenged by burnout, being pulled in a lot of different directions, all of those kinds of things. How do you take a topic that may not be the favorite topic of the person being asked and sort of fit that into the visit? But then also kind of at a maybe more of a like practice level question, how do we decide to prioritize this when you think about all of the other things that someone could be prioritizing? So that's kind of like a lot to throw out there, and I think we can certainly see if the report author wants to weigh in on this as well. But do you have any reactions to thinking about that?
Yeah, I think I can tell you just briefly like what some of the sort of studies do is that it's, there's a process of screening prior to the start of the visit. For example, a couple sort of have a screening process where people are identified at check-in and they either fill out a paper form or respond to the questions on a tablet prior to even, the start of the visit. I think, though, to me, like if particularly thinking about a short visit, um, that's just the 4 questions. Like the screening for this is generally short, but it's really that response, and so I guess that's my bias of thinking about like the more challenging thing is if you have a scheduled 15-minute visit and you have a person who, let's say, screened positive and it didn't sort of take up additional time, the response takes some time. And I think, the comments before about having adequate training to be able to respond during a sort of busy clinic day is incredibly important. But it also means that there really needs to be a clear plan for what the response is, and what specifically needs to happen during that visit in order to connect the person with an intervention that's likely to be effective or meet their needs. I don't know if I really answered the question well, but I think planning and considering ways that the screening happens prior to the visit, and so that doesn't have to be the person who's seeing the patient for the visit to ask the questions out loud necessarily.
Thank you so much. And I think it's helpful to hear what some of those other studies have been doing that relate to that. Any additional reflections, April, Joy, on that question?
Yeah, so we're going through this too as well, Ellen and Cindy, to your point. So I mentioned earlier team-based care so that it's not all on the clinician to ask this in the 10-15 minutes that they have. We do a lot of screening in terms of social determinants of health, right? And so that's why I was saying the gazillion of other quality measures and screenings and screen tools that everyone says, but this is important, right? It depends on who you're like. And so knowing that some of these questions we're able to ask beforehand, right? Whether it's via text, providing iPads in the waiting room, having a patient advocate ask the questions if they're less sensitive, and then leaving the more sensitive questions, i.e., we also screen for adverse childhood experiences, which I know we haven't covered here, or ACEs, IPV, leaving the more sensitive questions to the in-person interaction. And so it's just a matter of talking within the healthcare team, the healthcare systems you work in, to see which questions are okay for us to ask outside and which are really need to be between the patient and then the member of the healthcare team who may or may not be the clinician, right? There may be someone else on the healthcare team who the patient has better trust and rapport with that makes sense to ask the questions. So it doesn't all fall on one. Again, easy to say if you have a team-based care approach and have that, what others may call luxury. I recognize that may be limited or not applicable to those who are practicing where they're the only clinician. It doesn't necessarily have a team, but for those that have that kind of team composition.
Thank you. Thank you for that great discussion to both of you. I want to make sure that we have time to touch a little bit on the other report. So I'm going to ask April, Joy to sort of pivot a little bit and think about the maternity care report. And so my first question there is, how can healthcare policies encourage the adoption of respectful maternity care practices within diverse clinical settings? And here I'm thinking in particular about if we think about the absence of a standardized definition and validated tools. So how do you make that happen in that kind of a context?
So I think there's kind of 2 parts to that question. Regarding the absence of a definition, I think what we have learned throughout this session is that there are lots of thematic elements and overlap that could help systems and providers, clinicians come to consensus around a definition. And there are really, effective validated tools to measure that. Now, clinicians and health systems in the US often rely on HEDIS measures or performance improvement incentives and tools that kind of help incentivize adoption. So, I sort of wonder in this sense, is there a way to incentivize care in systems and think about, well, you have to measure it and then you have to link it to some sort of structured outcome that incentivizes clinicians and systems to want to deliver this care effectively and respectfully. So, I think there's lots of opportunities. We have to look at the limitations and also advantages maybe of some of the US healthcare system context. There's a lot of variability, but there are some that are bigger systems that have standardized primary care in various ways or have standardized hospital care. And so you have to kind of look across that whole landscape to think about creating some sort of standardization and agreement. And also, I think linking it to whether it's payment incentives or whatever is sort of driving people to adopt certain practices, in addition to identifying the barriers and the facilitators to adopting those practices, especially for preventive services, thinking about also importantly patient engagement. So engaging with the communities who are affected by these experiences and centering around building trust so that they become part of that care team as well.
Yeah, no, excellent points as we kind of think about what is that like mix of extrinsic, intrinsic factors that need to come into play, as well as when we think about, what can be done in sort of how do we guard against maybe like a more paternalistic model, right? And make sure that, again, patients are being incorporated in the team. April, Joy, any additional reflections on that?
Yes, so I am channeling Keisha virtually because my response is I really want to use this space to talk about the importance of midwives. So I think most people on the call are familiar with midwifery, but if not, so midwives, trained healthcare professionals specialized in pregnancy, childbirth, postpartum, sexual reproductive health, gynecological health, models of care associated with reduced maternal mortality and positive birth outcomes, right? A lot of research to show a decrease in the use of birthing interventions and increase in spontaneous vaginal births. Again, great research at the global scale, right? I think the US is actually catching up on this, shows that WHO shows that access to midwifery care could avert more than 80% of all maternal deaths, stillbirths, and neonatal deaths, right? But then in the US, states have shown, and we actually do a lot of research in this area and actually have implemented midwifery in our own practices, have a higher integration of midwives, have better maternal birth outcomes, lower cesarean rates, lower preterm births. Midwifery is the default birth care model used in other high income countries with better health outcomes than us, and that includes the UK, France, and Canada. And we wrote about this, my colleagues, our policy team talked about this. The advent of what we now know as modern obstetrics replaced midwifery as the default form of birth care in America in the early 20th century. So, and created monetary incentives for medical interventions, right? And so I think Amy also showed this in the timeline. So the Shepherd-Towner Maternity Infancy Protection Act of 1921 required midwives to be licensed and trained, right? At the same time, there were negative stereotypes about Black women not being clean, being responsible for the deaths of infants. You had the Hill-Burton Act of 1946 that gave grants and loans to hospitals and other healthcare facilities, which led to the rise of women including Black women, to give birth in hospitals, which further alienated midwives, right? And so I want to say, again, this is not just a matter of bad apples or bad actors, but actual policies being enacted that really siloed and marginalized midwives, and really recognizing that it is now coming to our attention in the US context. Again, this was already known globally, that the demand for midwifery has begun to increase in the US during and after the pandemic, but it is still out of reach for many families, right? Not covered by most insurance providers. There are midwifery assisted home birth restrictions. Sometimes some states have even outlawed midwifery. And so if there were a policy change, it'd be that of, really decreasing those barriers to midwives being able to practice, but also reimbursement of midwifery services.
Thank you. Lots of kudos and accolades coming through the chat. There's sort of shared perspectives as well as sort of cheering for the history lesson and things that are coming through. So thank you so much. As I look at the clock, it looks like we are coming up on the top of the hour. And I'll be honest, that 2 hours actually really flew by for me. I think we had fantastic presentations today, a phenomenal discussion. And so would really like to thank everybody for their attention, their engagement, their enthusiasm. There was a lot of really rich discussion here. So thank you for joining us and for participating in today's conversation. A huge thank you to the report authors, Cindy and Amy, as well as our discussant, April Joy. And then I'd also like to express thank you to our partners at AHRQ and the SRC as well. So as we wrap up, I'm going to ask, well, it looks like it's already in there, but we're going to share the CME survey link in the chat for anybody who's interested in seeking continuing medical education credits. And also, I know this was noted in the chat earlier, but we will be sharing the slides and the meeting recording as soon as possible. And we will be also announcing the next EPC Grand Rounds theme shortly thereafter. So thank you all again. This was a fantastic discussion. I hope everybody has a wonderful rest of their day and a wonderful holiday next week if you celebrate. Thank you.